This podcast was produced by OAR FM Dunedin with support from New Zealand On Air.
Welcome to the OI podcast, the Otago Institute podcast, in-depth conversations with experts from the worlds of arts, sciences and mātauranga Māori, brought to you by the Otago Institute, the Otago branch of the Royal Society for Arts and Sciences. Kia ora, I'm Dr. Barb, and today's show is Sleeping on the Job, and we're in conversation with Dr. Judith Penny. Kia ora, welcome Judy.
Thanks, Barbara.
So, full disclosure, I have known Judy since the first year that we went to Otago University.
Yep, we met in a line, didn't we?
We met in a line, yeah. So, yeah, and then Judy went on to do med school at the University of Otago here, and then I think you did a couple of electives around the place, and then eventually wound up in Perth, Western Australia.
Yep.
Oh, man. Amazing. So Judy is what you call a consultant. Oh no, I've gone the wrong way around. I'm sorry, listeners out there, and I know this is terrible, and I'm just going to have to admit it straight up. I've been practicing it all day, and I am terrible at saying these words. So she's an anesthetic consultant.
Very good.
Thank you.
Well done.
Oh, man.
Excellent.
Yes. Would you like to say all the verbs and nouns that go with anesthetic consultant?
Sure. So we practice anesthesia, or
Anesthesia.
In the United States, they would refer to it as anesthesiology.
Anesthesiology.
And so in sort of countries that have come from the British medicine tradition, we would be anaesthetists. But depending on the country you're in, sometimes you would refer to yourself as a specialist anaesthetist if you also have general practitioners that provide anaesthesia services, because they're kind of GP anaesthetists.
I didn't realise that there was such a thing.
We did used to have them in New Zealand, just like you'd have GP surgeons, GP obstetricians, but with the centralisation of specialist healthcare, I don't think there's actually any GP anaesthetists still operating in New Zealand.
Wow.
Whereas Australia's a different kettle of fish, because you've got we're a widespread population with rural centres that are very distant. And so if you don't have someone who can provide anaesthesia, then you can't really deal with people coming in the door who've had a car accident, or, maybe they just need their broken wrist fixed or something, and you have to provide some sort of safe anaesthetic services. So where I work, we actually do train GP anaesthetists to provide those services.
Oh, wow. Oh, yeah, so that's quite interesting. Because it is quite different in Australia to New Zealand because of the just vast distances.
Yeah.
And a greater population, but big distances between them with a lot of quite low population.
So I think that probably the last GP anaesthetist would have probably been operating in a hospital here like Westport.
Right.
Or, Greymouth.
So that's quite isolated on the west coast there as well.
And how, I actually don't know, I can't comment on what's happening there now, but when I was here, say 15 years ago, they were solely reliant on locum services, and so they would have locums from even other countries. Well, actually, they had South Africans for a long time. So there was a group of South Africans would come and they'd work for 6 weeks at the West Coast hospitals, and then they'd go back to South Africa and someone else would come.
Wow. And I guess that's the same as like the junior doctors here doing elective and going to
no, because they were specialist anaesthetists.
So they're higher up in their progression.
Yeah, they were getting a pretty good service over there. But, it's not easy because you don't get the continuity of care if you're getting someone who's only coming for 6 weeks.
Yeah.
They don't have the time, or they don't have the engagement to make changes. Right. I guess with these guys, because they were coming again and again, it was better than, just getting some random locum who you never saw again.
Right. Oh, so this was like the same ones would come back.
I think it was kind of like the whole department would just rotate out to New Zealand for a while, and they'd...
It's kind of a strange...
I know, but there's all sorts of weird situations. Where I work now in WA, there's lots of hospitals all around the place who are solely reliant on locums for everything.
Wow.
So they actually don't have any specialists that work in the hospital who live in that town. Wow. They're all FIFO, and you can imagine.
FIFO means fly in, fly out.
Fly out. Yeah,
and it's. I guess it derives from all the miners.
Yeah, and so it's just become a thing. And during COVID, that was really interesting because there was people that were just stranded.
That only meant to be there for 6 weeks, and then they ended up being
stranded in that hospital, stranded in that state. So, I mean, one of the hospitals that I have, sometimes go to these remote hospitals and do resuscitation training courses. And so you get to know a little bit about how they work. And there would be FIFO doctors flying from the East Coast to the West Coast, flying from South Australia to Perth and on to those, distant towns. So it's fascinating how these places work.
Yeah, no, it's quite a strange lifestyle in a way, isn't it? And I guess it's one of those things that you don't really think about unless you're involved or you know someone who's in that lifestyle.
Yeah,
and then
but it's a huge population of people who do FIFO work of all kinds.
But you're not a FIFO person.
No.
You have a garden.
I live a 10-minute bike ride from the hospital if I'm late.
Yeah.
Or a 15-minute bike ride if I'm slowing down, looking at the flowers and the kangaroos. So I can literally get out of bed at 7 a.m. and be on the job at 7:30.
Wow. That is amazing, isn't it?
Yeah.
I guess there's places in Dunedin that you can do that as well.
Yeah, that's true. You wouldn't be able to park your car.
Yeah, but you're not parking your car.
You could probably bike,
biking,
yes.
Yeah. So do they have showers in the, do you have a parking space for your bike and showers?
I don't go fast enough to get sweaty.
All right. Anyway, so Perth is quite flat though, isn't it? Is it or not?
Yeah, I mean, it's definitely not like here.
Right.
But there's the odd little rise. It's kind of like, dunes and limestone scarp, and so there's, those sort of things. But yeah, it's definitely flat compared to here. Right. And the other thing that isn't so bad is that we don't really get the wind. I mean, it's one of the windiest cities in the world, surprisingly, but that's because it's just constant wind. So it's constant wind, but it's not really high level. So, when you sometimes...
So there's always a breeze?
There's always a breeze, yeah.
Wow.
Except for the days where the breeze fails, and then it's like 1,000,000,000 degrees. Like if it's summertime, if you don't get that sea breeze, because it's basically, offshore, onshore sort of cycle.
Oh, right, okay.
And because the sea just controls the temperature. But sometimes that fails, and you get the heat just sits there over the land, and that's very oppressive.
Oh, yeah, no, that sounds terrible. Oh, that sounds terrible.
Yeah, but it's interesting because, I know we've segued into climates and that sort of thing because my parents are from New Zealand and they would say, there's no way we'd want to come in summertime. We would just die. We couldn't come in summertime. And it's actually not that hot all the time. I mean, it's hotter than 30 degrees, but it's not hotter than 40 degrees all the time. Like we would only have, maximum, 1 week, 10 days, excess 40 degrees. Yeah. And it is a problem when it's several days in a row because it just builds on the temperature the day before. So everything just gets hotter and hotter and hotter.
Oh, that sounds crazy. Do people go crazy? Does that flood the ER with people doing crazy things because they've just kind of...
I don't think so. I don't think so, yeah. I've never heard anyone say that.
Right,
I think people generally stay home.
Because there's air conditioning now.
Yeah, I mean, only 40% of Perthites have air conditioning.
Really?
Yes.
Wow.
And so I don't know how the hell the rest of the people are surviving. Some people live by the coast, and so they've got the sea breeze. They can go and have a swim.
And are their houses just maybe designed for better? Or?
They are designed to be drafty.
Yeah.
And so it's that's great if you've got a breeze, but if you haven't got a breeze, then all the heat just comes in. Yeah, so single glazing, everything just gets hotter and hotter, and so people are reliant on air conditioning who have it, and heaps of the houses have pools, and so I always say that air conditioning has ruined the pool for people in Perth because what people would used to do is they'd just go and sit in the pool all day, and so some of the pools are built with like a swim-up cocktail bar you see in some resort.
I don't understand them, eh?
They have little tables, and so you just sit around on this little seating area in the pool, and then you have your, just live in the pool
nice, though, doesn't it?
all day, in the pool, out of the pool, in the pool. But if you're in the air conditioning, you don't even feel that hot.
Right.
And so you're like, I suppose we should go in the pool. Yeah, so it was completely different
energy in the 70s. Wise, going in the pool must be way
more sensible than using the aircon.
Using the aircon.
Yeah. But everyone's got solar. And so
power.
If you've got solar, well, not everyone. I mean, it would probably be, I reckon, 70% of people would have solar.
That is quite high.
And I'm just guessing. Okay?
You're just guessing.
I'm out of my scope here.
No, I totally know that you.
But it looks like that. Some suburbs, it honestly looks like 90%.
Like it's enough that it gives you the impression that a lot of people have solar, right? It's not unusual to have solar.
And so, you run your aircon during the day, and of course that's the cheapest thing to do, whereas at night time you're paying higher prices for your power. But you're getting back to my parents. So they would say, oh, we're not coming in summer, there's no way we could hack it. And I just say, think about if you're living in a really cold country where you don't leave the house for a couple of months in winter because it's just horrible weather, too cold. Whereas Perth is kind of like that during the day. You don't go out walking, and in fact, we're the only people out walking often because we're crazy Kiwis.
Right.
Everyone else is just hiding inside their houses.
But you're all covered up with shade hats and long sleeves.
What we do is we use evaporative cooling, and so we will literally wet everything we wear, and we try and find, it sounds weird, but we wear quite thick shirts because they stay wet the longest.
Right.
And then you just walk until you find a drinking fountain or a public toilet, and you just wet your clothes again. And we sometimes take a spray bottle and just keep spraying ourselves, spraying the kids, and because it's a dry heat. There's all these cliches about Perth. It's a dry heat. It is true. It is a dry heat. And so evaporative cooling works fine. We've tried it also in Singapore. It doesn't work so well.
No, I can imagine.
And you look disgusting.
Yeah.
Yep. But that's how we go out and, and exercise during the day. But so mum and dad, they come over, go in the pool, hide in the house, and then the sun goes down and temperature's awesome.
Yeah.
So you can still go out.
It doesn't sound too inhospitable, does it?
It's not. It doesn't last that long, and the dry heat is much more tolerable than
the humid heat.
Yes.
Yeah. No, crazy.
Yep.
So just getting back to the whole Anesthetic Consultant. See, that just tripped off my tongue that time.
Well done.
Did you always want to be a doctor?
No. So I didn't know any doctors. I'm not a child of doctors. It just wasn't on my radar at all, and I had the idea that I wanted to be a property valuer because I did some work experience with them, and it was an awesome job. At that time, you could get a government job or you could have a private job, and you just cruise around to people's houses, measure this and that, look at all sorts of things, and then you'd come up with, you know how QV comes up with the value of your property? It's that sort of thing. And I'm sure it's all done by a computer these days. And
government valuation, that sort of thing.
Yeah. It's hard to know. It's hard to know whether these jobs will last into the future. But it was an excellent job in those days because you just cruise around and perfect people's houses.
Yeah, it's such a strange concept that's actually a job, really.
Yeah, I don't know how I stumbled across it, but
so why did you not do that?
Because I left in sixth form, went straight to university, and I just remember being overwhelmed by how everyone else seemed heaps more worldly wise. There was lots of older people coming to university for the first time or after having had a break, and I just thought, gee, I've been studying a long time. And I've been working quite hard because in order to leave from sixth form, you had to do quite well.
It was called something then, wasn't it? Preferential entrance or something?
Remember.
Yeah, there was some, I don't know, there was some wording for it.
Yeah, it wasn't UE, I don't think. That was
UE was a different,
Yeah. But, and so I thought, they're right, I need to go and see the world. I've just felt a bit burnt out with studying, and the idea of then spending another 3-4 years churning out projects after projects was just a bit much for me. So I left and got minimum wage jobs, just mainly working in hospitality, and decided that I would go and see the world. And so went to Australia, didn't see anything else. My then partner, we had a panel van. You know what a panel van is, eh?
You like a van with panels on it?
Yeah, it's kind of like a ute, but you can get through. It's kind of more like a station wagon, so you can get from the front to the back. And
right.
And that was our home for about 3 months. And so we decided we were going to travel all the way around Australia. And so we started in Sydney, got as far north as Hervey Bay, I think. And then all the Queenslanders said, why do you want to go any further? Because Queensland's the best state in the world. It's the best place in the world.
Right, and you just believed them and stopped?
No. We thought, yeah, sure, they're going to say that's what Queenslanders are like.
Yeah.
It's a pretty good place. And so we did stop, and then we got stuck there for the next 2 years. But in the course of travelling around, I bought a book which was kind of like it was about women's health, and it was the first time I'd ever learnt about anything to do with health, and I was just blown away. I was like, this is amazing to have this knowledge and to be able to, know what's going on with your body and health and, preventative health and all that sort of thing. And so I thought, I want to be a part of this. So it was pretty much an epiphany that was where I was going to go.
Wow.
I had no idea how much doctors got paid. I had no idea what sort of things you could do apart from, GP.
Apart from just being a normal, like what you think of as a normal doctor.
Yes,
GP.
that's right. So
Yeah.
I had no idea what I was.
Crazy.
But I knew that was the sort of knowledge that I wanted to have,
Wow.
and I wanted to be able to, give other people that same feeling of empowerment if they.
So you must have been,
about their health.
by that stage, you must have been sort of early 20s, right?
Yeah, so I actually had to go back to high school. So I was 20 when I went back to high school. And I went back to my same high school that I'd left.
Wow.
Yep, all my same
that's-
teachers, but I was an adult student. They actually had they had a little separate room for all the other adult students, and most people were. I think we started off with maybe about 15 people. Finished the year with about 3, because most people were coming after they'd had to leave due to having babies or whatever else had happened. And it was very hard to combine full-time study at a high school with small kids, and so not many of us
it's set
lasted.
hours, isn't it?
Yeah, and and so that was a bit of an experience. But because at that age I was so motivated, I worked really, really hard. And it sounds a little bit unfair, but I got Ducks of the School, which is, like the supreme.
I don't think that's unfair.
Yeah, but it kind of is, because I didn't have all that teenage stuff distracting me. I didn't have the,
but I mean,
the
teenagers
discovering
don't have to have all that teenage stuff
boyfriends
distracting
and
them, do they?
girlfriends and partying and, all that stuff that young people
But
do.
you were obviously quite intelligent anyway, right? Because you had already had good enough grades to have gone to university.
That's true, but my superpower was hard work.
Right.
So, and I would just game hard work all the time. So, I would go and sit in the detention room at lunchtime and do all my homework. I would do my homework on the bus. Just any time I had, I'd just do my homework. So there was, I don't know. It's just I am one of those people who I can't tell how I'm going to do in a test, so I have to know everything.
Right.
I can't just say, I think I've studied enough, I'll be fine. I have to know everything.
This is true. She is like that.
It is, and
I used to study with her, and she was really like that.
it is a bit of a chick thing as well. Like
could
guys,
be.
guys will know a
Yeah.
little bit. No, it's just a thing
Yeah.
that blokes will have an amount of knowledge, and they'll say, I just have to pass.
Yeah.
Whereas I was like, I want to do as well as I possibly can.
Yeah.
And so I wanted to know 100% of the stuff, which gets harder and harder as you go through university, because and obviously
Because there's more and more stuff to know.
With
the more you
medicine,
know,
the
the more
field
you
just is
just
endless.
explodes.
It's endless, and so at some point you have to say, okay, what are you actually going to test me on? Just this big pile of books. So all of these books, I'll learn all of them. So, but eventually it does become overwhelming. You have to accept that you're not going to be that straight A student. Without
That's not true, though. You were a
without
straight A.
lot
You were a
of
straight A
work.
student in
Yeah, but
med
it took a
school.
lot.
It did
of
take a
work.
lot. Yes, it did.
Yeah, and so
But that's
as
what made you the best study partner ever.
Oh, that's nice.
Best study partner
But
ever.
as far as the usual things that most university students are doing, exploring the opposite sex and themselves and being independent and all that sort of stuff, and I didn't really do any of that.
Yeah, but I guess by the time you got to
I'd
university,
already done that.
and
got it out of my system.
Yeah, because there was so even though you weren't that much older, you were still like a couple of years older going into university.
And it does make a big difference.
Yeah.
But what happens with older students is that you get caught at the other end, because if you take too long to get through your medical degree and then do your specialty, and then maybe you do a fellowship or some other subspecialisation, then unfortunately it gets harder and harder to pass those exams.
Right.
Because
Your
it's
brain
just,
starts to get old.
unfortunately, it's just a natural decay of
God, it's
your
crazy, isn't
brain's
it?
ability to focus. And then you've got other stuff that turns up, kids, partners, mortgages.
Parents getting old and
having to
needing
work
care
70 hours a week, stuff like that. So you kind of
So
get caught
what
at the
made
other
you
end.
go into anaesthetics?
So yes. Well, as a medical student, you rotate through all these different specialties, and you kind of you're trying to pick what you think you'd enjoy, and you're also trying to pick the sort of people that, it's probably subconscious. You pick the sort of people that you think you could get on with.
Right, because you're spending most of your time
Well,
with them.
I guess it's who seems like you.
Yeah.
You know, and so some of the specialities, like unfortunately some hospitals, you might have a collection of people who are a bit mean.
Yeah.
And or you know might have someone. All it needs is one person in a certain department, and we all know that because we've worked in places like this where one person can suck the joy out of the whole department,
just, like,
and
sets
it
the
trickles
tone for
down,
everything.
and everyone's unhappy and ground down. And so certain specialities were like that, and so it's possible that I would have enjoyed them in another hospital,
Right.
but and so I did go through a few specialities, just trying them out as a junior doctor.
Yeah. And is that quite normal though?
It is quite normal because if
I guess there's some people who've just always wanted to be an obstetrician.
Yeah,
or I don't know, a surgeon or
some
something.
people did know. Some people
And so
knew
they're just
from
like, I
medical
just want to be a
school
surgeon, I
that
just want to be a cardiologist,
they were definitely
whatever.
going to be an eye doctor, and a lot of people I know have gone on to do that.
Yeah.
But most people do some sort of process of elimination, and sometimes what looks fun as a medical student doesn't end up being fun actually working in it. And I remember doing anaesthesia. I think we did it for maybe 3 weeks, 4 weeks, and I thought, geez, this looks boring. and I
then
kind
15 years, what is it, 20 years later?
Yeah, I fancied myself as, like a house kind of doctor. You know, that
right.
program House.
Oh, yeah, like a diagnostician. Like Hugh Laurie.
Yeah, him, yeah. And so when a fresh patient came along with all their signs and symptoms,
because that's the whole detective
I
thing.
know,
It's just,
and it was so exciting.
So
it was so exciting.
Yeah.
I'd be like, oh, it
and
could
it's
be
like
this,
puzzle
and it could be
solving.
that.
Like you've got all the things, and you've got all the.
I loved it.
Oh, yeah.
And then 3 weeks later, like you start off and you had like a 14-point plan, or you'd have a 14-point problem list, all the things that were wrong with them.
Oh, right.
And then you'd
Are you saying
look
it's
at this,
not
and
as
you'd look
clear
at
cut
that,
as
and
it
you'd
looks
look at this, and you'd look at
in-house?
that, and then 3 weeks later, who knows? You don't know what's wrong with them. It's weird, most of the time you find out what's wrong with them, but sometimes it's like, yeah, it could be this and it could be that, and they just got better and went home, or it ended up being a whole collection of social problems. Like, what it's like having aged parents is they come into hospital because they can't be at home. And so they've probably got a whole bunch of things wrong with them. They've got multiple, we call them comorbidities, and it's basically multiple disease processes which are causing them problems.
And there's, of course,
And
there's
some
people
of
in
them-
society that are more reluctant to go to the GP or to go to
Absolutely.
any doctor.
Yep.
And so that by the time they get there,
It's a crisis
It's a
point.
crisis.
Yeah.
It's an emergency of some sort.
Yeah.
And they've also possibly built up a whole lot of other things that just haven't been treated,
Yeah.
which would have been just tiny little things, and you can't tell
Yeah.
if they're part of this crisis point
Yep.
or just something that's been unattended for.
And sometimes you can
Yes.
modify those diseases, and sometimes you can't. And so, but oftentimes you'd end up in the situation where, yes, okay, we're able to fiddle about with this and adjust this medication and diagnose this and treat that, but you'd still be at the point where they're not going back home. And so it's funny because I'm probably talking about general medicine here, which is your physicians like House, and so they're not the specialist cardiology doctors, they're not the respiratory physicians.
Because he's got his mate who's the oncologist, and
so
one of the
they-
junior doctors is the neuro.
I haven't actually watched House, but
Sorry.
okay.
Sorry. Anyway,
But I haven't watched House for years, so I'm not sure I couldn't comment on it. But oftentimes television programs are very weird. Like, do you remember Shortland Street? How those doctors did everything. One day they're
I
doing.
didn't watch Shortland Street that much, but
Well, it was years ago. One day they were doing
It's still
cardiothoracic
on.
surgery, and one day they're doing plastics, and it just doesn't happen like that in tertiary hospitals or any hospital.
So you're saying that Shortland Street is not?
It wasn't true to life when it first
It's
started.
not true. Oh, wow.
I haven't watched
I
it
mean,
yet.
maybe it's true to life now. We've not
don't
watched
know.
it, but it is
I
still
doubt it
running.
because they'd have to employ so many more actors.
Yes, that's probably
Yep.
true.
All the other shows are the same. They're just doing everything, and that's not how it works.
That's not how it works. So
Anyway, but
everyone
I
specialises
don't
into
actually
something.
watch medical programs because I'm too annoying.
Oh, right. Okay.
So I'm like, oh, that wouldn't happen like that.
Yeah.
I know,
I'm
it's
like
clearly
that
this.
with the background plants in movies. Like, I never managed
Really?
to make it through The Last Samurai because it's supposed to be set in Japan, but it's got clearly
wrong
New Zealand
plants.
endemic native
Yeah, well, it
plants.
was filmed here, wasn't
Yeah,
it?
it was filmed here. And I was like, and lots of people watch it because it was filmed here, and I'm just like, no, sorry,
Can't do it.
I cannot get that. What do they call it? That suspend disbelief type thing that you have with movie. Once that is broken, it's broken, and you can't get it back. And that's
Yeah.
why I hate programs or movies that break that fourth wall, except for Deadpool, because that's kind of funny.
Okay, I'll take your word for it. And so,
Anyway.
back to the story. So I love medicine, but and all my colleagues love medicine, but it's kind of like the dumping ground for all the situations where the specialties can't help, and so you'd often end up with difficult situations.
Oh, so when you say medicine, what are you talking about?
Oh, sorry, talking about general medicine.
General medicine, yeah.
Yeah, which is anyone who's kind of got a complex situation that doesn't fit in neatly into another box.
Right.
Like they're not just coming with a heart attack. They're not just coming with pneumonia. They're coming with
a bunch of things.
Yeah, it could be
high
confusion,
blood pressure,
or they can't walk, or fever of unknown origin, all those sorts of things.
Right.
And so, and while it's really interesting trying to hunt down the cause, it's also really exhausting.
Right.
And it's funny because some specialities are harder than others.
Yeah.
And
it must be quite frustrating as well, as if you do all of these things trying to hunt down the cause of this thing, what is the thing?
Yeah.
And really unsatisfying when there is just no way to tell if it's this or this.
And that happens in other specialties as well, because, we only know how to diagnose things because things fit neatly into a box. And there's lots of specialties where things don't always fit neatly into a box, like rheumatology is one of those things.
Right.
You often have people that might fit over lots of different boxes.
Right.
And so, they're kind of like a miscellaneous. Anyway, moving on. But I was working really hard. I was probably working, 60, 70 hours a week, coming home at 7 o'clock, 8 o'clock every night, and just making sure that my patients were all sorted. And so I probably didn't have a lot of balance in my life, and so I tried doing emergency,
Right.
and they were limited, probably because of safety reasons. They were limited to only working 45 hours a week.
Right. Yeah.
And all of a sudden, I was a better person.
Yeah.
I didn't even know I'd been unhappy.
Right.
All of a sudden,
But
I
that's quite
felt
crisis.
lighter.
That's 45 hours of crisis. It could be really calm.
Yeah,
it could
but
be calm.
I
There's
think it was
nothing
just
happening,
having the extra time, so better sleep,
Right.
Being able to exercise, having social stuff. It's all
Right.
better for your mental health. And so I was a different person. I thought it's actually quite nice being this different person, because I was a better daughter, I was a better partner, I was a better friend, all those things. And so I thought, that's interesting. But I thought ED was fun and I liked it, but I wasn't sure that I saw myself doing it forever, because it's quite fast paced.
Yeah.
And so it's really good for people who are 20s, 30s, 40s, but can you hack it in your 50s and 60s? It's less likely. So you ideally need a career that's going to last the distance.
Right.
And so someone said, why don't you try anaesthesia? And I was like, oh yeah, try that. But I did like the anaesthetic department.
Right.
Because they really support their trainees.
Right.
So if you call and you say, I'm having a problem with this patient, they will come.
Right.
Because
Which is really reassuring, right?
Because if they don't come, that patient might die.
Yeah.
And unfortunately, I didn't feel as supported in other specialties,
Right.
because people do die all the time.
Oh, right, yeah. I guess
they're
that's
often at the end of their lives.
Yeah, and I guess that's the
very
difference,
severely
isn't it,
unwell.
right? Because if they might need the operation, but the whole part of putting someone to sleep for the operation, that is something that's...
You're taking someone well.
You've done it.
You're taking someone well, and you are essentially giving them drugs and doing processes to them that if you weren't there, they would not survive.
Yeah.
And so it sounds scary, and a lot of people are scared coming in having an anaesthetic because they don't do it every day.
Yeah.
And, a lot of people worry about that loss of control. But, we are very well supported and very well trained.
But you love it now, don't you?
Yeah, it's a great job. It's a great job.
So it's interesting how that as you've matured, you've sort of changed your idea of what.
Yeah, well, it is sometimes difficult as a medical student to see exactly what the job entails, because they're not going to let you do everything.
Yeah,
they're not going to let you
'cause
do all the exciting procedures that you do as a
and I guess that's the thing with anaesthetic
trainee or a specialist
consultant thing, is that it is so fine. Like a little bit of wrong drug.
Yeah.
Then like it's quite. I imagine if you just were in there and you were like me and you knew nothing about it, and someone had just given you like a cheat sheet, it might be all right. But as soon as something goes wrong,
that's the thing. Yeah,
correct me if I'm wrong here, but I imagine if as soon as something goes wrong, it goes wrong really quickly.
Yeah,
and you need to know what's happening and what to change.
And so you actually have to do pretty rapid assessment of what's going on.
Yeah.
And so we basically learn kind of like drills or quick little algorithms. Have you ever read the book Thinking Fast and Thinking Slow?
Yes, I have. It's a great book.
So we're often being aware of that, because oftentimes your first instinct is the right one.
Yeah, but quite often it's also the wrong one.
Well, but if you're, if you think, okay, well, I'll try this because it's probably this, and then if that doesn't work very quickly, then you've got to think, okay, so now we're down at the, we call it, this type 1 thinking versus type 2 thinking. Type 2 thinking is your methodical.
Go through the points.
Yeah, going through the steps. Okay, eliminate this, eliminate that. But you're talking about trying to do something really quickly because maybe the patient's oxygen's dropping, or they haven't got a cardiac output, so they've essentially.
What are the main things? Like their heart stops or they stop breathing?
Okay, so when people say, like everyone that comes to have an anaesthetic, they're worried about generally two things. They're worried about, could I die?
Yeah.
Oh no, there's probably three things. They say, could I die? Will I be awake when the operation's happening?
Right.
Will I say stupid stuff and embarrass myself?
Oh, really?
Yep.
See, now I just had a couple of operations last year and none of those things crossed my mind, so that I might just be like... Like it was a small operation. It didn't occur to me that I might die.
Yeah.
I mean, it did occur to me because the anaesthetic consultant said, there is a small risk that you might die.
Yeah.
And that is always one of the small risks of having any operation, I imagine.
Yep.
Anytime that you have, because you could have an allergic reaction to something that could be something that you don't know. It could be like whatever. But it's more like the risk seemed very small compared to the gain from having the procedure.
Exactly. And the thing is that 40 years ago, people would have come for their operations and, we had a fairly paternalistic model of medicine then, and I would have said, oh, hi, I'm your anaesthetic doctor, I'm going to put a drip in, and now we're going off to sleep, so, and
count backwards from 100.
Yeah, that sort of thing. And so because we thought that patients didn't want to be worried about all these risks that we thought were so rare, they didn't really apply to them.
Right.
And so, but now we're in an environment where we have to legally inform people about the risks and benefits. And obviously, if you don't have the anaesthetic, you can't really have the operation.
Yeah, obviously, yeah.
But for some people, sometimes we get patients and they are so unwell that we have a term we say, I wouldn't anaesthetise that person for a haircut.
Right.
And so it's such a big risk to anaesthetise them that we actually say, no, we don't think it's worthwhile.
Right.
So you're going to have to manage their condition conservatively.
Right.
Which is, meaning with medication and other sorts of supports rather than having an operation.
Right. And it doesn't really matter how bad the operation. I mean, I guess if the operation...
Well, that's what I mean. Like
if they're going to die without the operation, would you still say, no, we can't do that?
Sometimes we get pushed to do things in an emergency and we know that the patient has got... we think the patient is going to die within 24 hours.
Wow.
But this is their only chance. And so everyone just accepts that that's what we have to do.
Yeah.
So, I mean, an example of that would be someone who has a road traffic accident and they come in and they've got multiple injuries. And so you have to anaesthetise them so that they can stop their liver bleeding to death and, all those things. And so that's a different category.
Right.
So you're definitely going to give them a go.
Because if you do nothing, they're just going to be dead within minutes. Right.
That's right. So so that's a different kettle of fish. But I guess I'm thinking about, people that have got multiple things wrong with them.
Yeah.
Maybe they have like an end-of-life injury, like maybe they fall over and have a massive brain bleed.
Right.
Or they
like a broken
fall
hip,
over and break
maybe.
their hip and they're so severely unwell and that's why they fell over.
Right.
And so sometimes we say... more and more we are fixing those sorts of injuries and just taking the chance, but it is difficult because you can imagine that every operation involves resource use.
Yeah.
And so one operation that one person gets is an operation that maybe someone else doesn't get.
Yeah.
And we're in a healthcare system that doesn't have limited resources. So, and depending on the healthcare system,
resources.
Doesn't have unlimited resources, yes. Yeah. And so depending on the healthcare system, people are more or less likely to push ahead and do certain cases. And I certainly have seen that difference working in Australia versus New Zealand. So
it's interesting.
It's not unusual for me to say this would never happen in New Zealand.
All right.
So you asked about whether you can die under an anaesthetic, and the good news is if you're young and healthy and it's fairly minor or even most major surgeries, is the chance of that happening is extremely small. And so the sort of things that we could catch as unawares would be something like an allergic reaction, but we all train all the time how to deal with those sorts of rare events. And I can ring the bell in my theatre, and I'll have 10 people will arrive, and we all work like clockwork to make sure that your chances of you dying from that event is extremely small. And so what we would usually say is that you have a greater chance of having a car accident and dying on the way to the hospital than you do from dying from this anaesthetic today.
Right. Well, that's pretty reassuring.
Very good. I try
Very
to be reassuring.
Yeah.
You should be reassured.
Yeah,
I mean,
and I
modern
guess,
anaesthesia is very safe.
It's very safe.
Getting safer and safer all the time.
Yeah.
We're very well trained.
And you're so well monitored.
Yep.
And you're all nice and relaxed.
Yep.
And you've had a good night's sleep, and you have a good work-life balance. So
that's the one.
You're there, wide awake,
well
ready
supported.
to do it, well supported. And that's what we want from
well
the health
trained.
service. Yeah.
Yeah, what we're saying? So risks.
Yeah, but I mean, just going back to I guess what's the main job of an anaesthetist?
Yes, well,
consultant.
it is.
So is it just that bit
keeping the
person
patient
alive,
asleep and alive? So keeping the patient asleep so that they...
Because it's bad if they wake up during the middle of the operation,
That's right. Yeah, that was the second thing that people worry about. Yeah.
And does that ever happen?
Unfortunately, it has happened. And
how does that happen?
Okay, so it's less likely to happen now, although not impossible. The high-risk situations in the past were people that were coming with major trauma, or they're so unwell with sepsis, like
blood poisoning
infection, and they're so unwell that if you give them a normal anaesthetic, then they might just die.
Right.
Because all of our anaesthetic drugs, they have they make the blood vessels go relaxed, and so all of a sudden all the blood pools in your legs and arms and things.
And that's why they get you up to stand up straight away now if you've had an operation.
No, that's not really why they do that.
Okay, carry on with your thought.
But
don't let me interrupt.
No, you can. And some of our drugs make the heart slower and maybe not beat as strongly.
Right.
And for someone like you, no problem. I could give you tons of anaesthetic and you'd be fine. I mean, eventually, it would be too much. But young people are much easier to anaesthetise.
Young listeners, I'm young.
Yes, listen to that. It's easier to anaesthetise than older people because your systems are just much less robust.
Right.
And if someone comes in and they're very, very sick, then we have to be really careful about how much we give them. So sometimes we select different drugs. So we might say, okay, this drug, maybe they've got a slightly increased risk of being confused afterwards, but it doesn't matter because we're not going to wake them up anyway for hours. They're going to go to ICU.
Right.
And so you'll use this drug, which has less of a deleterious effect on the blood pressure. And we'd often give other drugs to support the blood pressure so that we're already giving something to help squeeze those blood vessels back up as we're giving the anaesthetic. And we might do different monitors as well so that we're able to look at the blood pressure more closely. So there's all sorts of things we do to try and reduce that risk of the person having a big drop in their blood pressure and their cardiac output.
And that's quite dependent on the person and the person's history and what specifically they're having the operation for and what other conditions they might have.
Exactly. So
one thing I really noticed, so I'm just going to interrupt you here.
Perfect.
One thing I really noticed is that before you go and have the operation, it's the anaesthetist that you spend time with, and sometimes you even have a pre-appointment with the anaesthetic team.
Yeah.
And there's a whole lot of questions and stuff, and I wondered, because that must be collecting that information so that they can make a plan for what medicines you might need to have on hand if something goes wrong, or what you're going to use at the start.
Yeah, so, I mean, you have patient factors, so are you pregnant? Are you old or young? Are you at risk of certain complications? And then you'll have pathological factors. So, what sort of diseases have you got?
Have you had a heart attack in the past?
Have you got
they were concerned about asthma quite a lot.
Yeah, I mean, asthma can be a problem
because it's all about your lungs
sometimes.
And breathing and stuff.
Yep.
And what else were they wondering?
And then there's procedural factors. So for the surgery, do we have to have the patient completely still? You can imagine if you're having spine surgery or brain surgery, if the patient was to suddenly, twitch or cough or move or something like that would be bad.
Yes.
And so, so you have to work out those sorts of things.
So for those surgeries, do they tie you down so you don't move?
No.
It's all on you to keep them sleeping and still.
Yes, so there is 3 components of anaesthesia, one of which is sedation. So that's the sleeping medication. So I'm going to give you some medication and you're going to feel all nice and floaty and off you go to sleep. So that's the sedation.
Yeah.
So we do some procedures just with sedation and that's it. So you might have that for a colonoscopy or maybe a
something that's
biopsy.
not so painful. Is that right?
That's right. Something
painful.
Where you're not going to have to give them heaps of pain reliever drugs because it's not super painful, and if the pain does happen, it doesn't last very long.
Right.
And
like a needle prick or something.
Yeah, something like that. Yeah. Like maybe you're having, or for a child, maybe they're having a CT scan and they need to just stay still.
Right.
Stay still, not wriggle around.
Right.
So they might just have the sedation component of it.
Right.
The next component is the analgesia, which is the pain relief. And and it sounds weird because you say, well, why would I worry about giving people analgesia because I'm just giving them some
they're
sleeping
asleep,
medication.
right? They can't wake up and be in pain. But can people be in pain while they're asleep?
Well, they are, because even though you have given them the sedatives so that they're not aware of what's happening and they're not forming memories about what's happening, at the very basic level, so at the the very most primitive spinal cord brainstem level, they're still getting that information telling them about painful things happening.
Oh, right.
And so we're always watching for...
So your heart's still going...
Yeah, so you've
had your leg chopped off, you're really in pain, but your brain's not registering it.
That's right.
But your heart and your blood pressure and everything is still registering, hey, I'm in extreme...
Blood pressure can go up.
Oh, that's interesting. I did not realise that.
Your breathing rate can go up. Sometimes people, they might even be,
clenching their teeth or
sweating or, have tears and things. And so,
wow.
We want to give people the amount of pain relief that's suitable for the pain that they're experiencing at the time of the operation
how do you know how
and
much
for
pain
afterwards.
they're in?
Well, it's kind of like, how do you know how much pain they're in?
Yeah,
like
some
these
people,
signs.
Because some people are more painful. Like
that's right.
Some people have more pain than others. Like I don't know how to say that. Like some people, like if you hit a whole lot of people on the head with a hammer, some people would be in more pain than others.
Absolutely. Yeah, there's huge variability, and so we're watching all those signs.
And is that thing about redheads being?
Yeah, there has been...
Because there was some research,
a whole bunch of different papers.
About it's not redheads, it's the genes that are linked with people who have red hair.
And we don't know why. And we still don't know whether it's actually a thing. So, and that's the thing with medicine. I'm sure you've seen this in other areas of science, is you'll have a paper and it'll say this, and then you'll have a paper that's different, slightly different design, or maybe it's a different population, or it's a bigger population, or maybe they've got better randomization, or whatever, and then it'll disprove that.
Right.
And then you'll have a whole bunch of other papers, and then you're back to where you were before.
And then do a big meta-analysis.
Exactly.
Because ecologists, we love the whole Cochrane reporting thing.
Yeah, so you probably need to do a whole talk about interpreting scientific data.
Yeah.
Because for the public, I think it's exhausting. They say,
it's like,
this is bad for you.
This is bad
now it's good for you, and this is bad for you. And so they think, just make up your mind, guys.
Yeah.
But
that's not how science works.
No, science takes the best evidence they've got at the time, but then some better evidence might come along, and they're still considering that other evidence, but maybe this evidence, with that evidence, means that things have changed.
Yep.
So it's always changing, it's always evolving, and so we just have to go with it, I suppose, do the best.
And then I guess at the medical front, like right there where you're dealing with patients, that's quite a lot of work to keep up with what the latest science, what the latest research is.
Yeah, so I don't read every single anaesthetic paper, but we go to, we have to continue our professional development. So that means keeping abreast of the latest changes. And so probably on average I would go to 1 or 2 conferences a year, and then we will talk about different
So that's
cases.
just a conference that's just got anaesthetic consultants there. And then you all have workshops or lectures or whatever. And then I guess also just talking around things that have happened, cases that you've had.
It's lifelong learning. And as part of what we do, we have to talk about cases. Like sometimes we talk about cases that are coming up. What do you think you would do?
Yeah.
What
So it's
someone
all,
else
so
done
it's
in
all
another
anonymised.
hospital.
So there's no no one
That's
knows
right.
who the person is.
It's all completely de-identified. But and you want to have a whole lot of different brains thinking about you if you're a tricky case. I mean, no one wants to be a tricky case.
Yes.
But it helps to get ideas from
all the
different
folks
places.
said I was a tricky case. I was very unusual. I was a tricky case. I don't know. I felt some sort of weird satisfaction from.
Did
being
you?
I didn't know.
It's
It's a
fantastic.
weird. I don't know how brains work. But yeah.
So analgesia. We work out. What do most patients need for this procedure?
Right.
What sort of issues does the patient have already? And so things that you wouldn't necessarily expect. So things like alcohol consumption, things
Cannabis.
like other drugs can often mean that patients have a much higher pain requirement if they are already on pain relieving drugs. So maybe they're already on opiates like your morphine and your oxycodone, etc. And so that means that they've already got that tolerance to the opiates, and so they might need 20% more. And so you're
So that's why it's
all that
really
stuff.
important to actually be truthful,
honest
with.
about your drug and alcohol use, because it affects whether we're able to give you enough anaesthetic and enough pain relief.
So no one's going to turn you into the police or anything, because I guess it's all that doctor-patient confidentiality anyway. So it's
not in anybody's interest.
So it doesn't make
to
any difference.
Not be honest about it.
So just be absolutely brutally honest.
Yep.
Yeah.
And
what was
so
the third thing?
The third thing was muscle relaxation.
Right.
And sometimes we call that muscle paralysis, because if we give a lot, then you will be paralysed.
Oh my God, forever?
Temporarily.
Oh,
temporarily, and it wears off. Or these days we've got an agent that can make it wear off within a couple of minutes. Yeah, it's
so that just stops you moving, right?
So it stops you moving because you know how I said about the brainstem thing.
Yeah.
So say if someone poked you with a sharp stick, then your natural reflex would be to jerk your leg away.
Yes, that's true. And you can't stop yourself doing it, even though you know it's not going to hurt.
No, and so and people will have no memory of that. They might not have indicated at all before that they were not having enough pain relief. And so that's the other thing about pain relief, is that the more pain relief we give people, it kind of means that we don't need to give them as much anaesthetic.
Right.
And so, rather than giving them a whole lot of anaesthetic that maybe puts a bit more load on their
So that's the
system.
that's the sedation one that's actually making you go to sleep.
Yes.
Right.
We kind of adding in the pain relief side of things, and it means that the whole cocktail is better for them.
Right. So a little bit of muscle relaxant, a little bit of pain relief, and a little bit of sedation is better than a massive amount of sedation. And
it's kind of synergistic.
So it's kind of get that balance
That's right.
between the three things. And I guess that depends on how critical it is that they say absolutely still.
And not everybody needs to be absolutely still. I mean, if you're having your ankle fixed for your broken ankle, it doesn't really matter if you were to move a little bit during what they're doing, whereas if you were operating on someone's gut and the patient is breathing and their diaphragm's coming down or their muscles are tensing up, it makes it much harder for the general surgeons to operate. So there's certain operations that do require patients to be completely still, and so sometimes we will keep running the muscle relaxants the whole time, like an infusion, which is a continuous drip.
Right.
And we're watching all the time with a little monitor that sees when they start to get some muscle recovery coming back. And so we're keeping them as deep as possible with the muscle relaxation.
Wow.
Where I work, because we don't do brain neurosurgery, we actually don't do that very often.
Right.
And so what's changed with the muscle relaxation in the last 20 years is that there's a drug that reverses some of the muscle relaxants that we use.
Right.
And it was actually developed by the company that makes a particular muscle relaxation. And so it's an enormous coup for them, because people all want to use all their drug.
Because you can turn it on and turn it off.
That's right.
Yeah.
And so and every surgeon seems to think that that's what you can do. Wake the patient up now. I've finished, wake the patient up. And
that's not like that.
No, and in the old days, you had to be sort of like watching them the whole time and thinking, how close till the end, because we're going to have to stop giving them muscle relaxant so that we can start to get ready to reverse it, and then we'd have to wait 15 minutes, and then we'd have to check again, and maybe we have to give another dose, and blah, blah, blah. Whereas these days, you can keep them fairly deeply relaxed with their muscles and then give them this antidote, if you like.
Right.
And then
That
within
just
2
reverses
minutes,
it. Wow.
within 2 minutes, they, breathing and moving.
So I guess,
So that's been a major game changer.
Because I guess that makes it easier to schedule things, does it? I mean, because it must
means
be
that
hard.
there's less unexpected delays.
Yeah, because they don't know.
Because
Like when
everybody's
they're doing an
different.
operation, you don't act, like you have an idea, like
Yep.
an appendicitis or something. It might take this amount of time, but if something goes wrong or something's different or there's just some difference,
That's right.
Something, and the more complicated the
Yes, and so and
the
sometimes
surgery, the longer.
Sometimes that is frustrating for patients, particularly if you're on what we call an emergency list. So
Right.
you come in and you might be competing with all other people who have got
Right.
things that need fixing. And so they're trying to determine who do we do first.
Right.
Who we do first is generally the people who have the greatest need. The sickest people, emergency operations, and sometimes it can be a scheduling thing where you've only got a surgeon that can do that operation available in that time, or sometimes it's an equipment issue because maybe you've had to send away for special equipment, or you've just used your equipment and now you have to sterilise it for the next case. There's all these sorts of factors that can that work into how lists are scheduled.
But is that you that does that, the anaesthetist?
No. So it's a combination.
Because that sounds like quite a complicated job.
Yeah, it is.
Just
and
juggling
so,
all those things around.
So the surgeons generally they'll come up with a list, and then what we would do at the beginning of the list is do like a huddle where we all get together and we talk about what our issues are. They talk about what their issues are. The nurses talk about their issues. Maybe they've had a whole bunch of nurses who are sick that day.
Right.
And so they're really struggling, and so it might mean that we can't work through lunch. We'll have to stop for lunch, maybe we say, well, actually, this patient needs an ICU bed. Have they got a bed in ICU? Oh, it turns out they haven't until the afternoon. So we might have to delay that person till the afternoon. And so patients will often say, when am I scheduled? And I don't want to tell them.
Yeah, because it's
if
the first thing.
If I say 10 o'clock,
Yeah.
then they'll be annoyed that 10 o'clock rolls around and it's not until 12 o'clock. Because it's hard for patients because
And they're getting hungrier.
Fasting. Yeah, they're fasting.
That's what I always say.
And that's another thing that is changing in the anaesthetic sphere is that we only learnt about fasting, probably in the 1940s when patients would
really?
aspirate.
So what is the fasting thing about?
So good question. So fasting is really important so that stuff doesn't come up from your stomach and get into your airway and cause
Because your muscles are all relaxed.
fatal condition called aspiration pneumonia. And so if we don't fast people, it doesn't mean they can't have an operation. It just means that we always have to use a breathing tube that goes down into their windpipe, and we do their anaesthetic really quickly and get that tube down as quick as possible.
Right. Because I always wonder that, because people who have a car crash and then they're going for an operation straight away, they're obviously not fasting. So why do you have to fast? And
why do you have to fast? Because it's safer for you, and it means that we can make the choice between two different types of airways. So there's the tube that goes down into your windpipe, which can sometimes give you a slightly hoarse voice and maybe a bit more of a sore throat. And then there's another airway that just sits in the back of your throat, holds your tongue out the way so that you breathe normally. Or sometimes we take over the breathing and make sure that enough air is going in and out.
Right.
And so that's basically the choice. And so even though we try and do the anaesthetic as safe as possible for people who aren't fasted, it's still a higher risk situation than someone who is fasted.
Right.
And even
so you
then,
shouldn't cheat, basically.
Oh,
And if
no.
you do cheat or forget,
please tell us.
please tell us.
Yeah, please tell us. Yeah. So
that's
we've
interesting.
all been caught by people saying, oh no, I haven't had anything to eat for 6 hours or 8 hours or whatever your fasting thing is. And then someone goes off to sleep and then pours their chocolate milkshake.
Right. Because they didn't eat it, they drank it.
Yeah.
Oh my goodness.
Yep. Or there's the other one where you say that they're told, don't have any breakfast, and then they turn up and they say, yeah, I didn't have any breakfast. I did stop for a pie on the way though. It's morning tea. And it's basically because we've obviously done a poor job of explaining to patients why they're fasting, and it's to prevent a potentially fatal complication.
Yeah. So it's no food and I guess no drink.
No food for 6 hours.
Yeah.
And you can have clear fluids, and depending on your hospital,
so clear fluids
up until
is
2 hours.
water,
But
isn't
it depends. It honestly depends on your hospital. Do what your hospital says. Do what your anaesthetist says. But we're starting to let patients drink for longer and longer.
Right.
Because the hazards of being dehydrated makes it harder to get a drip in.
Right.
Blood pressure drops more after you anaesthetise them.
But clear liquids does just mean water, right?
You can have black tea, black coffee.
It's a weird phrase, isn't it? Clear liquids.
Yeah, I mean, apple juice is usually okay, although some people worry about the sugar content increasing the gastric
I always
contents
worry
level.
about the sugar
so
content.
just do whatever your hospital says.
Yeah. And if you're not sure, I guess the best thing is to just, when you're having that pre-talk with your anaesthetist, just
ask
them
the question.
Yeah.
Yeah.
When you say clear fluids, what does that mean?
Indeed.
Yeah. I ask lots of questions.
Good.
Yeah.
I think that's good. It's good to be informed about your health, and no question is too stupid.
Yeah.
We're definitely happy to.
And you're not paying by the question. That's really useful to know. You're not paying by the question.
Yes.
Yeah.
And we definitely do like to see patients ahead of time. In fact, our college encourages it because patients aren't very good at taking in information when they're stressed, which is
like right before
is
very, I guess, is the most stressful time.
Yep.
Yeah, whereas you kind of a bit more,
and people only remember 20% of what you tell them.
But you can take in a support person as well, can't you? And then they can remember stuff for you.
Yeah, absolutely.
Not to the actual operation, but to the pre-op
interview. And sometimes, depending on your age and your situation, they sometimes can come to theatre. So oftentimes parents will come with children.
Right.
Into the theatre.
Yeah. Hey, that's just about all we've got.
Well, my goodness.
That's all we've got time for today.
That was a very small foray into the world of anaesthesia.
I know. I've got so many more questions, and I'm sure everybody else has more questions, but we've just got 7 seconds left. I thought I would just let you say hello to Andre and Devon and Brett back home.
Yeah, so hello, Andre and Devon and Brett. So I'm almost like a media megastar because I've been on Barb's
the OI podcast. Yes. Hey, and folks at home who's listening to this, if you enjoyed this interview, which I'm sure you all did, you will probably also like the one with Professor John Reynolds on the blood-brain barrier. Ka kite.
You've been listening to the OI podcast, the shout out for the arts, sciences and Mataranga Māori.
You can support this podcast by becoming a member of the OI. Check out the Otago Institute for Arts and Sciences on Facebook or our website.
If you'd like to listen again to this episode or others from the series, look for the OI podcast on ORFM's website, oar.org.nz.
Brought to you by the Otago Institute for Arts and Sciences, the Otago branch of the Royal Society of New Zealand.
This podcast was produced by ORFM Dunedin with support from New Zealand On the Air.